different case scenarios which we face daily from the lab point of view and the clinician point of view. The first case scenario, a 60-year-old male patient admitted in ICU from emergency with fever, vomiting, pain in abdomen since 3 days. Patient was very restless. ICU resident orders blood for culture and sensitivity. Nurse withdraws 10 ml of blood from the peripheral line and deposits in the culture bottle. After 48 hours, no growth in blood culture bottle. So how to interpret this result, sir? RGK, sir, how will you interpret this result?
I think, so initially I'll speak and then So basically, one thing which is probably the most important factor in a blood culture is the volume. So in this patient, only 10 ml has been cultured. That is definitely suboptimal because with the increasing volume, the sensitivity of pickup of organisms increases. So the current guideline is to take at least 2 sets. That is each set optimally comprising of about 16 to 20 ml. So that is a total of about 40 ml distributed into 4 bottles. That is 2 sets. So with 40 ml, the sensitivity rises up to around nearly 90%. So with one, that is 10 ml alone, it's probably only 70. So even though the culture is actually negative, you can definitely not rule out an infection, and the sensitivity of the culture should have been increased with a higher volume also.
So is there a need to do aerobic and anaerobic culture? How differently do we process it in the lab?
Usually in adults, the usual recommendation is to divide the blood into anaerobic and aerobic bottles. But again, I think according to the situation, you can take a call. Usually that is a practice in our hospital also. But then if there's no suspicion of an anaerobic infection, probably you can do away with the anaerobic bottle. But then to have a uniformity of culturing, probably you can keep one set equal to one aerobic and anaerobic drawn from one single site. That's how we practice.
So is it always mandatory to have 2 culture sets, or can we go with only 1 culture set?
Yeah, so usually to make a diagnosis, to make an etiological diagnosis, it is ideal to have 2 sets, with probably the exceptions being probably in a neonate or a child where it's not possible to take 40 ml. So usually it's said 1% of the body weight, up to 1% of the body weight is the volume you can take out. So in a pediatric patient, if you can only draw about 1 to 3 ml and say there's no suspicion of an anaerobic infection like say necrotizing enterocolitis or something like that, you can just put it into a single aerobic bottle and send, so that you can maximize recovery.
So in what way the lab can also help the clinician? Like if the amount of blood deposited in the blood culture bottle is less, how can a lab interpret and talk back to the clinician?
So there are a couple of ways that you can do this, like you can weigh the blood culture. So the uninoculated bottles all have a standard weight. So one thing that the lab can do is probably weigh the bottle and say, and something more easier than that would be the blood culture bottles are graduated. So the lab can themselves look at what level the blood is filled up to and feedback it to the clinician.
I think even the clinician or the nurse who collects a sample can also look back whether
do that,
it's been correctly collected, or does this blood culture bottle requires more volume of blood before we send it to the lab. So this is a slide on how we are supposed to take the blood culture based on blood volume for each age group depending upon the weight. But the general rule of thumb, a pediatric age group above 3 kg, you can draw from 1 to 3 ml each in 2 sets. That is, it comes around 6 ml of blood in each set. The number of blood culture, as clearly told by Dr. Nandini, it increases the sensitivity. So the pickup rate or the yield for the blood culture will increase if the number of sets are increased. Case scenario 2, a 30-year-old male patient presented with complaints of fever, headache with vomiting to ER. Blood culture, 2 sets collected from ER, grows 1/4 bottle of gram-positive cocci. No comorbid illness. Patient is clinically stable with no device in situ. How to proceed with?
Yeah, so the first thing you do is to treat the patient. Don't treat the blood culture bottle. So the patient is clinically stable. We have 1 blood culture bottle which is growing out of 4 sets. We all know that when you have just 1 bottle growing out of many sets, it often comes from the skin. You know, people in emergency are often hard-staffed. There is a big rush. So cultures are collected in a hurry. So if your patient is stable and there is just 1 culture growing gram-positive cocci, probably it represents coagulase negative staph, which is a common skin flora. And if your patient is stable and does not have any clinical presentation consistent with staphylococcal sepsis like an abscess or cellulitis, don't treat the patient. Just keep looking for other causes of fever. Somebody with fever, headache and vomiting possibly has a meningitis. So you need to proceed clinically rather than look at these blood culture bottles.
Nandini, Dr. Nandini, can you just explain the difference between a coagulase negative staphylococci and a coagulase positive staphylococcus?
Okay. Like in this case, it's just a GPC in one out of the 4 bottles. So, like Dr. Ajike already said, it could either be a cons or probably one of the alpha streptococci, which may be just commensal flora. So the first thing, I mean, the next day when the growth comes, I think the easiest thing that any lab can do is do a coagulase test. So the coagulase test is the one is positive in Staphylococcus aureus, which is the pathogenic species of Staphylococcus. All the other species come under a bracket called coagulase negative Staphylococci, which are all normal flora again. So then again, I mean, if you go into technicality, it's probably tube coagulase and slide coagulase. Both of them are positive in aureus, whereas there are a couple of exceptions where only one of them is positive. So for all practical purposes, coagulase positive is Staph aureus and coagulase negative are other normal flora.
So is it an easy test? The result can be given within an hour or maybe within 4 hours?
Yeah, the slide coagulase actually can be given immediately within a half an hour. Tube coagulase for 4 hours.
So for the clinician point of view, if you are running across such a case, you can definitely ask the lab for a tube coagulase test. At least you can get the report within 4 hours, which will help you to lead your way forward whether I need to treat my patient or not clinically. So these are the examples of coagulase positive. The recognized pathogen is Staph aureus. The coagulase negative, which are the less virulent. The most common skin commensals are the Staph epidermidis, Staphylococcus hemolyticus, rarely Lagunensis and Staphylococcus saprophyticus. Scenario 3. A 33-year-old female patient presents to ER with fever since 1 week, cough, difficulty in breathing since 5 days. ER resident orders for 2 sets of blood culture. Instructs the nurse specifically each set to be drawn 1 hour apart. So what is the importance of timing of collection? Is there any importance that we should collect one set at one time and the next set after an hour, or we can collect the blood sets both together?
The timing between blood, see, first of all, why do we separate cultures? Why don't we just draw 40 ml from one time and just put it into 4 bottles? You know, patient is happier. We spoke only once. Why do we say 20 ml and then 20 ml later? This is to separate your volume draws in time. Because if you contaminate that one stick, like in the previous case, all your bottles are contaminated by the skin flora. You won't know what is truly causing the infection. Whereas if only one bottle is contaminated at different time points, you can strongly say that that is a contaminant. So that is why you space it in time. Now the time interval depends upon the clinical urgency. If my patient is in septic shock, 5 minutes is enough because I have to give my first dose of antibiotic within 1 hour in septic shock. That is what all the guidelines say. So within 5 minutes, my second set can be drawn. On the other hand, if my patient is a stable fever of unknown origin with a heart murmur, embolic manifestations, etc., then I am thinking of endocarditis. For me, that blood culture information is crucial. And you know the criteria, the Duke criteria and endocarditis say blood cultures at least 1 hour apart. So in that stable patient, you will tell them draw it at least 1 hour apart. So it all depends on the clinical scenario.
So for all practical purpose, if we are not thinking of infective endocarditis, the blood set has to be drawn from 2 different sites. Probably a gap of 10 to 15 minutes is more than enough for us. Not to wait for 1 hour before we give antibiotics.
I'll just add one thing. Actually, by definition, one set is actually one blood culture which is obtained from one site. So when we say 2 sets, it actually means 2 pricks only. It doesn't ever mean that you have to take 40 ml from the same. So however you space it, one set is actually 1 prick. So, and sometimes the nurses will just take, randomly take one from one side, put it into 2 aerobic bottles, and the second prick into 2 anaerobic bottles. It becomes difficult for the microbiologist also to interpret that the result of those cultures. So one set is 1 prick actually.
So for one set contains 1 aerobic bottle and 1 anaerobic bottle. So 1 prick, 10 ml should go into aerobic bottle, 10 ml into anaerobic bottle, which constitutes 1 set. For the second set, another prick has to be done. So as sir already explained that the clinical condition for which timing matters is about infective endocarditis. For acute endocarditis, you are supposed to draw minimum 2 to 3 sets of blood culture and from separate sites within a period of 30 minutes to 1 hour of each other and before beginning your antimicrobial therapy. and begin therapy only after the cultures are obtained. Moving on to the fourth scenario, gram stain. Importance of gram stain. Is it mandatory to do gram stain always? Can we not go with the cultures?
Gram stains, in microbiology, when we talk about rapid tests in the lab, the first thing that we actually talk about is a gram stain. So especially for specimens that are obtained from sites that are normally sterile, a gram stain is the one that's really going to help you guide therapy. And this is usually in our critical call alert list also. So any sterile site specimen like an abscess, from a deep-seated abscess or a synovial fluid or a CSF, anything that's positive on the gram stain is immediately informed to the clinician, and that helps to guide therapy. But at the same time, if you look at samples which are from normally contaminated sites, where you expect a lot of normal flora also to be there, it's not going to be useful, especially some, like the ones that are listed here, sputum and wound swabs, which are usually superficially colonized. Sputum, especially the gram stain in sputum, is only done for the lab to make sure that it is not a saliva sample and just a sputum sample. So it's really not going to help therapy.
Maybe gram stain will be useful to identify the morphology of bacteria or arrangement of the bacteria.
Yeah.
Will it give an idea to the clinician?
I think, again, that is only in case of normally sterile site sample. I'm sure you would have read about pneumococci having a beautiful morphology on sputum, but then it's really difficult to differentiate your normal alpha streptococci, which are normal flora of the oral cavity, from pneumococci. So sputum is really not going to help therapy, but definitely any sterile site specimen, synovial fluid, abscesses, deep-seated aspirates, and CSF, pleural fluid, all of those, gram stain is the first rapid test that you should think of.
Maybe in a gram stain picked up from an intra-abdominal abscess, it shows gram-negative bacilli in the gram stain.
Intra-abdominal abscess is again
and if something doesn't grow on the culture, probably we can interpret it as an anaerobic growth. Which,
So many labs don't have specialized equipment or facility to do anaerobic cultures. But if the gram stain showed something and nothing grew on an aerobic culture, probably you can think of an anaerobic and treat accordingly.
So, clinician's view, is it laboratory responsibility to share the gram stain finding or clinician's interest?
Yeah, so like I said, it's in our lab, it's there on the critical alert list. So whatever is positive in any sterile site is definitely communicated to the clinician, but that may not be the case in every lab. So if you know that you have sent, and many a time it happens that samples are sent without a site of specimen or a source of specimen. So if you have not mentioned that in your requisition, we will also not know what it is. If it just comes as a pus, we don't know if it's a diabetic foot pus or a synovial pus or something like that. So when you know that you have sent a valuable, precious invasive sample, it is also your responsibility to call up the lab and ask for what is there on the gram stain.
So if it's a lab attached to hospital, it's not a problem. If you are outsourcing a lab, maybe you need to call the...
So the requisition needs to be complete, and also there has to be obviously communication.
Sir wants to comment.
Yes, it is primarily the lab's responsibility, but it is your patient. If you've drawn some pus out from a joint or you've drained an abscess, you want to know whether it's gram positive or gram negative, because you have to pick your antibiotic. The whole treatment hinges on that. So it is your responsibility to put pressure on the microbiologist. They hate my phone calls because I know that I'm putting pressure on them. See, we take so much of pressure from our patients to get them better. So we should transfer some of the pressure to the microbiologist to give us the reports quickly, because the treatment hinges on that. So it also facilitates a good outcome for the patient.
I think it's really nice to get his calls because we also know the patient. So it's always good to have, for the microbiologist also to have a clinical correlation of what we're seeing. So even we treat every sample as a patient, and the more clinical details we have, the happier we are.
So the importance of gram stain is it helps in scoring system, as we told, to differentiate between it's a salivary sample or a sputum sample for anaerobic growth differentiation. Morphology of bacteria. Few bacteria can have morphology which can be interpreted on a gram stain. Specimen collection, where the sample, if the sample has got a polymicrobial growth or a major amount of normal flora is there, probably you can return the sample back and ask the clinician to redo the sample if it is possible. Inadequate sample, if the sample is not adequate, probably the clinician send 2 wound swab and ask for gram stain, culture sensitivity, AFB stain, AFB culture, which is not possible for a lab to process. At least a gram stain will give an idea about what kind of bacteria are we expecting and what we need to treat. This is a Bartlett score to assess the quality of sputum. If the pus cells is more than 25, probably it's a good sputum sample, and the squamous epithelial cells, if it's less than 10, it's a good sample to be processed in the lab. Dr. Nandini, what are the basic alert organisms which a lab should call and tell the clinician, right from bacteria, fungi, or parasites?
Okay, so for bacteria, like I said, all positive organisms from any sterile site should be, like in our lab we inform all the blood cultures, and any CSF, gram stains or growths, any sterile site specimen for that matter, pleural fluid, empyema, that kind of this thing we definitely inform. Fungus, definitely something that is so, invasive mucormycosis like aseptate hyphae or even septate hyphae from a normally sterile site like a lung or a sinus, these things are something that will be informed. Parasites definitely, of course, and we don't look at, but then of course, malaria, microfilaria, any of the hemoparasites, and yeah, so those are the usual alert organisms.
So whenever you suspect those infections, the lab also has to alert those organisms immediately to the clinician. Important one is again multi-drug resistant pathogen, for whom you need to escalate the treatment, or you may need to de-escalate the treatment if the bugs are sensitive. Few examples: septate or aseptate hyphae found in a KOH mount of any sample. As she told, sterile body fluids, blood, CSF or tissue. Hanging drop positive, we often send to the lab a stool sample to look for motility. So hanging drop positivity should be escalated to the clinician immediately. Streptococcal pyogenes from throat cultures. Positive AFB smear. This is very important, because the culture and sensitivity will take a long time from the lab to get reported. At least the minimal thing which the lab or the clinician would want to know is the AFB smear positive or not. Any multi-drug resistant organism, positive malarial parasite smear, positive sexually transmitted pathogen, because we need to intervene. For example, a wet mount done on a patient's vaginal swab showing Trichomonas vaginalis motility. Probably that is a significant finding by the lab which should be escalated to the clinician. Case scenario 6. A 28-year-old female was brought to OPD of surgery with complaints of swelling over the left lower back since 1 month, along with back pain and fever since 6 to 7 months. On local examination, swelling was noticed over the left lumbar and gluteal region, non-tender and soft in consistency. On ultrasound abdomen, a well-defined cystic thick wall lesion was noticed. On CT scan of abdomen and pelvis, a well-defined hypodense fluid involving the left psoas muscle was observed. Pus sample was sent from OT to lab after IND for culture sensitivity. So, if such a sample comes to a lab without a proper diagnosis, what are the challenges faced by a microbiologist?
Yeah, so I think I've already kind of spoken about the importance of a properly filled up requisition form. If not, at least a proper communication from the clinician, informing about the site of specimen and the source. So if it just comes as a pus culture, like I think the last line of the previous slide said, if it just comes as a pus culture, we wouldn't know how important it is. And even if there's a chance that the lab can do a reflex anaerobic culture in such a case, they wouldn't probably know that if it's a psoas. We wouldn't know if it's not. If I didn't know if it's a psoas abscess, I probably wouldn't do an anaerobic culture or something to recover anaerobic organisms also. So, yeah, pus culture sensitivity, please always mention what is the site of the specimen.
We may not do the AFB stain also, because usually the clinician asks for culture sensitivity. So they will do just either a gram stain or directly they will go for culture. If I know
that it's a psoas or abscess or a pot spine or something like that, probably even the microbiologist can call back and tell you that wouldn't you want us to do a TB culture or a smear also, in addition to just the culture and sensitivity that has been asked.
So what is a lending or helping hand by the...
From the clinician standpoint, I don't think requisition forms really help. You need to pick up the phone and speak to the microbiologist, because it's a very important precious sample. For instance, in this case, if you go back one slide, I would pick up the phone and tell the microbiologist, I am thinking of staphylococci, I am thinking of melioidosis, I am thinking of tuberculosis. These are all possibilities. Please look carefully on gram stain, do your concentration smears for these organisms, and I will even tell her, if the sample has not been sent for gene expert, please keep some sample for us. We will need to send it for gene expert later. So unless you communicate like this directly to the microbiologist, you will not make the diagnosis in this case. So direct communication is very important, even better than forms. So always have the cell phone number of your microbiologist handy and disturb them at night.
Or should we have to have a package like in our Apollo lab, we have a bacteriology pack, which involves AFB stain, gram stain, culture sensitivity, everything together.
That is true, but you still have to do that stain correctly. Many a time you do the high and dry, when you look carefully, concentrated, you will pick up those AFBs. So nothing like communication. It's okay to culture a lot of things, but nothing like communication, telling them what you're looking for. So always when you have a VIP patient sent to you, you spend more time on that patient, right? Automatically, carefully, get the history, etc. It's exactly the same with a VIP sample. When you speak to them, they will spend more time, they will get your bug for you.
Can you make it a diagnosis case scenario as tuberculous vertebral abscess going down the sheath which is continuous to psoas major? Can you say this?
You can't say that unless you confirm tuberculosis. For instance, the staphylococcus or melioidosis or any other infection can behave identically to this. I agree, TB is top of the list, but even if you diagnose TB in this day and age, as we'll know in tomorrow's lecture, it could be drug-sensitive, drug-resistant TB. So it's important to confirm the diagnosis in all patients. Clinically, I agree, TB would probably be top of the list. Yes, that depends on the size. Ultrasound, CT guidance, some guided by.
So these are the labeling way we need to send the specimen to the sample. At least each lab should at least create their own way of specimen collection and should lend this help to the clinician also that this is the way they are supposed to fill in the forms and send it back to the lab. The case scenario 7, yeast or gram-positive budding yeast cell. Which are those sites or specimen of importance? Does Candida or yeast or gram-positive budding yeast cell play a major role, or which are the sites of specimen which we need to give importance?
So actually, Candida is also, I don't know if it might be news to some of you, but they are also colonizers in many of the open tracts actually. So especially in sputum, I mean the upper respiratory tract or the lower urinary tract, they are all colonized normally also in especially more so in some patients. But in a blood culture or say a pus sample in a pancreatitis or in such cases, definitely a Candida is the infecting organism. So I would say that blood cultures is obviously the most important one. When it comes to colony count for yeast and urine, it is something that we do, but like for bacteria, there's no cutoff for Candiduria as such. There's no 10 power 4, 5, nothing is actually universally accepted. So I think in such cases, you just need to take a call clinically. If you have clinical risk factors, which probably Dr. Rajike will elaborate, you can probably take it as important. But in our lab, we only report the identity of the yeast. We don't do a susceptibility for yeast in case of urine or sputum because as such, we don't give it a lot of importance.
So are the all Candida albicans? Most of the Candida albicans?
Actually, right now, the most common Candida in our country and in my lab as well is Candida tropicalis. Albicans comes second or third probably. So, and all Candida is not albicans, all Candida is not fluconazole susceptible. There are many non-Candida albicans which you can just straight away take as there will be a high level of antifungal resistance in such species. Tropicalis of course not so much and albicans not so much, but there are other species like cruzi and gillamondi which are all more resistant than the common species of Candida, and they are all on the rise actually.
So what are the importance of these speciations? Why is it so important?
Yeah, just to illustrate that, microbiologists and ID physicians define music and noise. What is music to us? Blood culture. What is noise to us? Urine culture, sputum culture, endotracheal tube culture, Foley tip catheter, drain cultures. All this is noise, right? We don't care. Nobody likes noise. We all want music. So that's exactly the same for Candida. If it grows in blood, it is music. Please take it seriously, treat it. If it grows anywhere else, almost always it is noise. Ignore it, don't worry about it.
Can you please highlight us on the different species of Candida which carries intrinsic resistance to like amphotericin or like fluconazole?
Yeah, there are some common resistant species in India. The most important emerging one is this species called Candida auris. And actually this is a worldwide or emerging pathogen. We'll be speaking a bit more on that on the fungal infection session tomorrow. But this is a drug-resistant candida. It is resistant to virtually all antifungal classes, even the echinocandin classes. And there are some conventional resistant ones like Hemuloni, Crucii, Glabrata. But all these are details. If you have candida in the blood, treat it. If you have it anywhere else, don't worry whether it's resistant or sensitive. Just ignore it.
Case scenario 8, 21-year-old male patient, IIT student, hostelite, high-grade fever for past 7 days, vague right lower quadrant pain, febrile and spleen is felt. Which do you think will not help? CBC, MPQBC, urine routine, Vidal, USG abdomen or the blood culture?
Yeah, I think this is an easy question from the previous lecture.
Can we post the
Yeah, so we can ask them.
Yeah.
They've been listening to the previous talks. So. Which will not help. Vidal, correct. Yeah, see, the Vidal is a test of really historical interest for two reasons. One, lot of false positives and false negatives. Two, in this era, you don't need to make the diagnosis of typhoid. You need to know what drug it's going to respond to. So even if you diagnose typhoid, you can't use the right antibiotic till you get the sensitivities. For that, only culture will help you. So this is a very typical clinical presentation of typhoid. You should get blood cultures. And sometimes blood cultures don't grow because the patient has been on antibiotics. In that case, treat empirically. Don't go by Vidal test.
What is only 50? What is the importance of it? What is the significance of it?
If all your 4 bottles, we explained that each blood culture protocol involves 4 bottles, 2 sets, 2 bottles and then 2 bottles again. All the 4 bottles mean there is a high grade bacteremia. It means there is a large number of bacteria circulating in the patient's blood. Typically, Salmonella is a high grade bacteremia. So it reflects the concentration of organisms in the patient's blood. There are a lot of bacteria in the blood, it will grow in all the bottles.
But in case of Salmonella typhi, even it was 1/4, you would still treat it as typhoid. There's no question of the pathogenicity of the.
It's a case of typhoid.
Typhoid.
It's a case of typhoid, enteric fever.
But Vidal was 1 in 80. Usually we say that only 1 in 160 or something we should treat. So that is why we say Vidal is a test of historical interest. Vidal should be given up in 2017. We have better tests available. So it is time to move on. So please don't do Vidals. If there is one take-home point we want you to take from this session, don't do Vidal. Get blood cultures or treat the patient empirically.
These are the few facts on Vidal, that it's based on serological response to O and H antigen. It cross-reacts with other Salmonella species. Many other diseases can also cause a false positive Vidal. Prior antibiotic exposure also affects the titer. Anamnestic responses can occur. False negative in some patients don't mount an immune response, and sensitivity and specificity of this test is only 50%. False positive can occur in typhus fever, acute falciparum malariae, chronic liver disease associated with raised immunoglobulin levels, and disorders such as rheumatoid arthritis, myelomatosis and nephrotic syndrome. Moving on to the next slide, spot the error. A 33-year-old female patient, pus culture and sensitivity shows E. coli. Cefotaxime is resistant, cefoperazone sulbactam sensitive, piperacillin tazobactam sensitive, nitrofurantoin sensitive, gentamicin resistant, and meropenem sensitive. So what is the error in this slide?
So I think Dr. Ramsubramaniam covered these issues regarding wrong test. Remember, if you are going to test an antibiotic for a particular germ, it means the clinician will use that antibiotic for that particular infection. Will you ever use a drug like nitrofurantoin to treat a soft tissue infection? Never, right? It's exclusively a urinary level antibiotic. So pus should never be tested against nitrofurantoin. So that is one clinical error.
So these are the drugs which will be used purely only for urinary isolates. Norfloxacin, nitrofurantoin, and nalidixic acid. Cefazolin usually for uncomplicated urinary tract infection. Cefazolin reports can be given for a urine isolate. Spot the error.
Is digicycline used nowadays in the treatment for urinary tract infection?
No, digicycline should never be used because it does not penetrate the urinary tract.
Or maybe increased, please.
Oh, this is not seen.
Okay, I think
They have difficulty seeing. If you can
I'll
just read it out.
Yeah. A wound swab shows presence of E. coli grown in culture, moderate growth. The organism is sensitive to amikacin, amoxicillin, amoxiclav, ampicillin, cephalosporin sulbactam, ciprofloxacin, cefotaxime, ofloxacin, levofloxacin, and gentamicin. In between these sensitive and resistant, they have reported it as moderate sensitivity to cefuroxime, ceftriaxone, ceftazidime, cefepime, and cefixime. Resistant to azithromycin, aztreonam, cotri, norflox, vancomycin, linezolid, teicoplanin, tigecycline, and ertapenem.
I think there are more things right. I mean, there are more things wrong here than right. So, there's nothing like moderate sensitivity. I mean, the guidelines actually only have an intermediate category. And in this particular one, cefotaxime has been given as sensitive, and cefixime, ceftazidime have all given. I mean, they all basically, cefotaxime and ceftriaxone are both third generation cephalosporins. You don't expect any kind of difference in the susceptibility to the two. And it cannot be sensitive to cefotaxime and intermediate to ceftriaxone. And all these drugs that have been reported in E. coli, like vancomycin, linezolid, teicoplanin, they're all really wrong. I mean, they shouldn't even be reported in a gram negative. There's no spectrum for these drugs for gram negatives. They're all only gram positive drugs. And see anything else?
Yeah.
The diagnosis here is very clear cut. It is a bad lab. Please change the lab immediately and send the samples to her lab.
So are we supposed to do third generation cephalosporin, each disc diffusion, or only one disc is sufficient to report on third generation cephalosporin?
In the CLSI guideline, cefotaxime, ceftriaxone are all placed in the same bracket. It's only enough to test one, but then it's okay to test two in case you get some kind of discrepancy. You know, sometimes if there's a discrepancy, you don't use any of them. Even if, see, in this case, I wouldn't use cefotaxime because whatever is that moderate, I would still probably not be very comfortable using.
So these are the group of drugs which is used only for gram-positive organisms. Like they are not supposed to use these distribution methods for gram-negative, like vancomycin, teicoplanin, clindamycin, daptomycin, linezolid, macrolides, except salmonella and shigella, penicillin and rifampicin. For gram-negative, colistin, polymyxin B, aztreonam, and nalidixic acid.
Okay, Yamuna, if we can stop here, we can encourage some questions from the audience.
Okay. Yeah. I have only. Yeah.
We can keep going, but we want to stick to time. If you have any pressing questions on the issues we raised, we'll be happy to take it up.
And if you want to ask any questions, you're welcome. Whether it is this session or some of you had some questions in the previous session also.
Gram positive negatives are found, even though they are not treated, they become suddenly gram negative. Is this scenario present in your experience? Have you observed?
I don't think that bugs can change from gram positive to gram negative. Some infections are polymicrobial. For instance, abdominal infections, abdominal abscess, etc., appendicular abscess, they are polymicrobial. You have enterococcus, you have gram negatives, you have anaerobes. So in that situation, if you treat for one, then the others can predominate or can be found in pure culture, but the actual organism should not change. For instance, if you have a staphylococcal abscess, it certainly cannot become a gram negative later on. So polymicrobial infections is the only place where I could think of that. Yes, for instance, for an abdominal infection, you should always use empirical anaerobic therapy, whether you culture or not, whether you send culture or not. So metronidazole or some other drug which covers anaerobes is essential.
Yamuna, do you have some more?
This is the last lab report which I want the audience to interpret. It's a urine specimen showing 6 to 8 pus in the wet mount. Antibiotic sensitivity shows the presence of Staphylococcus aureus, which is resistant to penicillin. Clindamycin is sensitive, amoxiclav resistant, ciprofloxacin resistant, gentamicin sensitive, ampicillin resistant, and linezolid sensitive. At the end, they have reported it as methicillin sensitive Staphylococcus aureus. With this report, can we interpret that it is a methicillin sensitive Staph aureus? Can the lab report it? Or we need to have a specific disc which should be interpreted by the lab?
Actually, the drug which is used as a surrogate marker for defining an MRSA is cefoxitin. Although many labs would still report it as oxacillin because it's easier for the clinicians to understand that, many wouldn't know that cefoxitin is the one that is used to differentiate MSSA from MRSA. But in this report, there's no mention of either an oxacillin or cefoxitin. They've just straight away said MSSA. And this amoxiclav being resistant in an MSSA is likely because penicillin resistant and oxacillin sensitive organisms the mechanism of resistance is a penicillinase, which clavulanic acid should have actually covered. So an MSSA being resistant to amoxiclav kind of raises questions. So I really doubt the authenticity of this report being MSSA. So I would still probably go with MRSA.
So these are the few indicator disc which is used for the gram-positive organism, oxacillin or cefoxitin for MRSA. Clindamycin, erythromycin can be used along with a D test is important to determine the sensitivity for clindamycin. Again, Streptococcus pneumoniae oxacillin zone is important. Enterococci susceptibility to ampicillin and susceptibility to high-level gentamicin or high-level streptomycin. Always look into these disc diffusion methods to use for synergistic method of treatment for enterococcus. So these are the useful disc diffusion indicators for gram-positive organisms. So by this we come to end of the panel discussion session. So the take-home message is order tests which have a good literature support, interpret with caution the tests like Vidal, know your lab and always interact with the clinical microbiologist. Culture of culture, always do a culture then start your treatment because that is what will give you a way forward whether you need to escalate or de-escalate or stop your treatment. Thank you. Thank you, sir. I thank both the panelists. Thank you so much.